Today's presentation is eligible for continuing education hours. Please follow these instructions for enrolling in Cloud CME. This will provide you the opportunity to claim these hours and to keep track of any other hours that you might obtain from the Cloud CME system. If you have any questions regarding this enrollment process or have difficulties, please reach out to the phone numbers noted here on these slides. Hi, my name is Jason Libby, and I'm a nurse practitioner here at the Hospice of Southern Maine. I'm going to be speaking to you today a little bit about pain and symptom management in hospice patients. This shouldn't be considered to be the final treatise on medications, symptom assessment, and causes of symptoms or anything like that, but rather an overview of common symptoms and management strategies for hospice patients. A little bit about me. I graduated the University of Maine in 1998, University of California in San Francisco in 2002. I am certified as an adult nurse practitioner and an advanced practice hospice and palliative care nurse. And though it is somewhat scary to think about it, I am currently going into my 14th year of practice here with Hospice of Southern Maine. I have no disclosures to make other than I am employed by HSM. I've no financial relationships or association with any of the medication manufacturers or distributors. So thinking a little bit about why this topic is so important, I really sort of emphasize that the symptoms, especially when untreated, really create undue suffering and distress. And suffering and distress can prolong a dying process, and more obviously, you're going to create a lot of misery throughout that process. And though hospice deals and works with people within the sphere of death and dying, the primary goal of good hospice care really is quality of life management. And one of the easiest ways that we can improve quality of life for many of our patients is through good symptom management. And a core belief of hospice providers is that all patients deserve access to good end-of-life care. And when it comes to symptom management, this does not have to be complex to be effective. And we can really bring these tools to bear in just about any situation that our patients or their caregivers might find themselves in. So thinking a little bit about the learning objectives today, hopefully by the end of this, we'll be able to name some of the common medications and how pain and suffering negatively affect end of life. We want to be able to describe and talk about dyspnea and how we work with that. Think about how anxiety and pain and dyspnea are intertwined and some of the common medication treatments for these. And try to discuss a little bit about delirium and agitation and the mechanisms that cause nausea and how we manage this symptom as well. So we're going to go through this in sections, and hopefully by the end, we'll be able to look at these and say, yes, I got it. So let's start right off with pain. Pain is something that we've all experienced to some extent, and therefore I think allows us to be quite empathetic with our patients. We might not have had the severity of pain, but we all know the way that pain can negatively impact our lives day to day. When we're talking to our patients about the pain experience, we really want to involve a lot of consideration for how the patient describes that pain, how they describe the discomfort. The use of what language they use can be pretty illuminating. Many people will use words like discomfort or not feeling well rather than using the word pain. I think sometimes our society prizes stoicism so highly that admitting that somebody is in pain is almost admitting failure, admitting that they have lost, quote unquote, in the face of this unrelenting disease process. So really being open to different ways in which people might describe this discomfort. And, we try to use a lot of discussion about location, intensity, quality, and timing, because this information can help us guide both our decision making about what we think the cause of this pain or discomfort might be, but also give us a little bit of insight as to whether or not we think our interventions are going to be effective. One term that we hear a lot in hospice is people talk about pain all over, quote unquote, pain all over. And this can be referring to, somebody's total pain, that is different sorts of discomforts caused by different parts of either their acute or their chronic pain issues. But it can also really be used to describe the sort of the existential distress that they're under. And, the physiological reason for their pain is one thing, but the sort of global dread and anxiety and worry and fear about death and dying can really promulgate a very difficult to describe sense of discomfort for patients, and that pain all over is sometimes how that comes out. We want to be, exploring the idea of what is acute, what is chronic, and be thinking about the different types. So there kind of basically breaks down into nociceptive and neuropathic. Nociceptive pain is sort of that direct damage to organs or bones. Somatic kind of being used to describe the pain that's aching, throbbing. Arthritis would be a good example of this. Visceral pain is squeezing, cramping kind of pain. Oftentimes this is associated with lesions in the liver or the pancreas, or the kind of pain that comes along with pancreatitis. Neuropathic pain is sort of the descriptions in the name. This is generally due to damage to the nervous system. Oftentimes this is peripheral, but the sort of way people describe it is this burning, tingling, electrical, shooting. Think about diabetic neuropathies, hepatic neuropathies like with shingles, and then radiculopathies, again, sort of like cervical spine compression, lower spine compressions that cause those sort of radiculopathies in legs, shoulders, arms. Thinking about aggravating and alleviating factors, again, this is very basic sort of pain 101. And what's made it worse? Is it movement? Is it not moving? Have certain medications been effective? Have certain medications seemed to make it worse? And thinking about what have some of the adverse effects of some of these other interventions been as well. Sort of brushed over it in the last slide, but the use of standardized scales is important. Only because it's probably the best way to help determine if you're making improvement or things are getting worse for that individual patient. A 3 out of 10 for me might be somebody else's 6 out of 10, but if they both get lowered by 2 points, then that is still a way in which you can tell, like, I am making a positive impact. So those standardized scales can be helpful even when you are dealing with somebody who can't describe things particularly well. And then kind of being open to, what are the meanings and the cultural beliefs that people have around pain. Some people see pain and suffering as punishment for things that they've done in the past, and they will be very reluctant, perhaps, to accept interventions that will help them feel better. This is something you might need to explore with them and reframe as a way to help them let us bring into their lives some improvement in their discomforts. And then globally, for patients, we can really talk to them about how their pain has impacted their quality of life. For a lot of people, that means that they have become significantly less mobile. And we can talk to them about how managing this symptom can improve their functional status. And if we get away for a little bit from some of that clinical detached sort of language, when we say, if you've got somebody maybe whose greatest drug was, getting out on the porch to play, their guitar, but they haven't been able to because of pain, we'll sort of say, hey, listen, I'm not gonna make any promises, but if we improve this symptom for you, we might be able to get you back out on that porch doing what you love. So, thinking about the ways in which their pain has impacted quality of life and how the interventions can improve that may be something that sort of opens up their mind to the idea of allowing themselves to be treated. Acute versus chronic pain. This is, obviously a very clear idea, but it's really worth remembering that patients coming onto hospice likely have both of these going on. Many of our patients are older, so they will have some of these chronic discomforts associated with aging. And then on top of that, they are going to have this acute pain related to whatever their high hospice diagnosis might be. So you want to be very mindful that you're sometimes dealing with two different things. Patients for risk of undertreatment. Unfortunately, like many things, the burden of these fall along with our older adults. Um, like I mentioned before, a lot of these patients have already experienced chronic pain, sometimes for years, if not decades, and they've sometimes associated their coping mechanism, or rather they want to continue to use some of the same coping mechanisms for this new acute pain as perhaps they've been using for chronic pain. And sometimes that coping mechanism has just been grinning and bearing it, which may very well have worked for some kinds of pain, but oftentimes is not effective for management of acute issues related to things like cancer diagnoses. Um, Older adults, but this is certainly not just them, can have a real fear of addiction and a loss of control. What we try to do is help people understand that these medications are tools, no different than a blood pressure medication, no different than maybe a medication for prostate issues, that they are just tools to help treat the effects of a disease process, and really helping them understand that it is different to be dependent on something to function versus being addicted to something. There also can be some real cultural beliefs that by taking narcotics in particular, that you are giving up, that you're no longer fighting, that you are weak, and really trying to explore like what their pushbacks on pain medications might be if they're there, and try to help them understand that this is something that we can indeed make better for you. Um, with patients who are nonverbal, either cognitively impaired due to disease progress or through longstanding issues, you have to, really sort of work around their lack of ability to verbalize. You want to use their nonverbal indicators of distress, the scowling, the grimacing, the being combative, with care because they know if somebody turns me over, I'm going to be uncomfortable. And aggressiveness and resisting in care is maybe some of the most obvious ways in which we see people guarding against things that they know are going to hurt them, but they can't tell us. And this is something that we see manifest. A good example is perhaps a patient who is at home with pretty advanced stage dementia, who was not typically dealing with agitated behaviors, but seems to acutely have done so. A lot of times what we see is that some pain, whether again, oftentimes osteoarthritic or degenerative joint disease related, has gotten to the point where the patient's lack of frontal lobe control, their ability to sort of just tolerate something, is no longer there, and they can't communicate well what they're feeling. And so this comes out as sort of a generalized agitation. Sometimes the best way to manage agitated delirium is to trial some pain medications, and oftentimes we see that that is something that can be effective for our patients. So talking specifically about some medications, so we'll start with non-narcotic interventions. Acetaminophen and ibuprofen are very good first-line medications, and sometimes first line, but almost always adjunctive to medications like opioids as well. NSAIDs in particular are helpful in the presence of things like bony mets. They, obviously are working on swelling, and oftentimes a lot of the discomfort caused by these sorts of lesions are related to swelling. And so that medication can be a great way to add to the plan. Tylenol works really well as an adjunct for like nociceptive somatic pain. Obviously, a lot of people use that for chronic arthritic pain, and it makes sense that would continue to be a good choice. Celiac plexus blocks, nerve blocks, obviously this is interrupting that signal coming from the end organ site to the brain. This can include things like gallbladder, intestines, liver, pancreas, stomach, by actually anesthetizing that node and stopping it from transmitting that pain information to the brain. It can be really effective at managing the pain that comes from those sorts of areas, which can be incredibly difficult to manage, even with high-dose IV medications. We don't see a lot of this in our patients, and oftentimes if we do, it's something that's already been done as part of their palliative care plan, and oftentimes has been done prior to them coming onto hospice services. In that vein, epidural intrathecal medication administration is something we don't see often, but when we do, it is something that has usually been done prior to admission to hospice, and it's something that we will maintain. Introduction of medications into these spaces can be incredibly effective for management of symptoms. However, oftentimes there's the drawback of some significant loss of mobility. But if somebody's progressed to that point of using that trade-off, it's usually because the pain has been so severe that loss of mobility seemed like a good bargain for them. So some common narcotics used in hospice. So right off the bat, we start with morphine. It's very well tolerated. The hospice providers are very comfortable using it. They know the side effects profile. We like to use it preferentially because not only does it manage pain well, but it's also really effective for management of dyspnea or shortness of breath. A word about these medications, oftentimes you will see them listed with allergies or as allergies, and the allergies are listed as nausea or confusion or lethargy. These are not allergies, these are side effects. And seeing those listed as allergies should in no way make you think about not using that medication without further consideration. You want to be thinking about the patient's status. You want to be thinking about ways that you could manage the side effects if you think that medication would be the best choice for them. Itching, nausea, confusion, and lethargy are all really common side effects of mu-opioid receptor medications. And so we do utilize medications to treat the side effects for those. Hydromorphone or Dilaudid, we use that sometimes when people have documented severe renal failure or with a true morphine allergy, obviously. And with the renal failure, what we're worried about is the active metabolites of morphine not being excreted and accumulating in a rather haphazard fashion, so you never really truly know what the circulating dose is. So getting away from morphine from those patients really makes a lot of sense in order to continue to safely manage their pain. These are two medications, as well as the oxycodone and the fentanyl, that we frequently will do a rotation. So when somebody's either getting onto very high doses of these medications and not seeing any relief, or if they've been on them a long time and their symptoms are continuing to worsen, sometimes that reset, even to a drug within the same class, can provide some significant change and improvement in pain management. Oxycodone, it's got a really kind of a mixed record of effectiveness for pain management, and it's even less effective in our experience for management of dyspnea. It's got a significant hangover feeling for a lot of patients, though if people have been taking chronically, that might not be so obvious. That being said, it's just not a particularly good choice. I have found in my own practice over the years that I often see improvement in overall symptom management when I transition from oxycodone to morphine in particular. But it's very popular amongst providers in the community, and so patients are coming to us sometimes having been on it chronically, And making that transition sometimes can be a little bit of work, but it's usually worthwhile when you can do it. Another common medication would be transdermal fentanyl, so that's the fentanyl patch. This is pretty helpful because it's a very simple medication for people to use. They don't have to remember to take it. It's non-invasive, and for patients who are the right profile, it can sometimes be really effective. Unfortunately, that right profile is somebody who's neither too young, too old, too thin, too fat. You have to have just the right amount of adipose tissue. The problem with fentanyl towards the end stage of the disease, as somebody's physiology and their symptom burden is changing, is that it can be pretty difficult to titrate this effectively as somebody's pain is moving, quickly, like it's changing day to day. Also, you end up with some unpredictable diffusion of the medication, not only how it's moving across the skin into the adipose tissue, but how it's being released from the adipose tissue into the bloodstream can become a little wonky. And so getting away from that, especially somebody who is, perhaps a couple of weeks to, days of to death, it usually makes sense to rotate the fentanyl either to, Dilaudid or morphine. Methadone is a medication that honestly we probably ought to be using more of. It is it exerts actions on a couple different sites, both the mu-opioid and NMDA receptors. The NMDA receptor aspect of it is probably responsible for its increased effectiveness in management of neuropathic pain as compared to the pure opioid receptors. Methadone is really easily, rather readily available, oral form, IV form, and even in suppository forms. And so it makes it an excellent alternative treatment for both cancer and non-cancer related pains. You probably are most familiar with methadone as medication-assisted treatment for substance abuse issues. However, it really is an excellent medication for hospice patients. It's easy to dose once it's been started. However, initiating it and doing the initial titration can be pretty complex and oftentimes takes, it's only undertaken by an experienced provider because of the comfort levels associated with using it frequently. Another medication that we see people come to us with is tramadol. It's indicated for moderate to severe pain, but our anecdotal experience would really point to it not being particularly effective for the severe pain that is associated with end of life. See this a lot in patients in skilled nursing facilities or in the community, as the providers, I think, feel more comfortable with this. And honestly, I think the families feel more comfortable with this because it's not called morphine. It's kind of a common myth that it's not as potent as morphine. But the reality is a common dose of tramadol is 50 to 100 milligrams, which is equal to 5 to 10 milligrams of oral morphine, which would be a pretty reasonable dose for us to use for our patients. So sometimes it's a name thing. People are just terrified of the word morphine sometimes, and so getting away to calling, using something else has been the pathway that people have used in order to help people accept, patients rather accept pain management. Common narcotics, these doses are pretty standard across the board. I'm not going to read off all these doses, but sort of speak again a little bit about the methadone. You start at 5 milligrams twice a day is common. That will be different if you are, say, converting perhaps somebody's fentanyl and oxycodone dosing to methadone. There's conversion rates for that. But if you are starting it de novo, either on its own or as an adjunct to another medication, that dosing to start at is pretty common. Usually titrate that every 3 to 4 days because it takes that long to achieve serum levels. And then, effective dosing for this is often 10 to 30 milligrams twice to 3 times a day. It can be a lot higher. There's really not much of a ceiling on methadone, and to wit, these other medications, the ceiling doses that we would use would be much higher than you would perhaps read in like your reference guides. The amounts and the frequencies aren't terrifically important, except how they inform us as to either effectiveness or to the point where we start to get concerned with things like opioid-induced neurotoxicity or hyperalgesia. When we see escalating doses, persistently high doses, and we're not getting the results we want, it is important because that then informs us that we're probably looking at treatment failure. And we might want to get away from that medication, not because the dose is high, but because it's not working, or we are getting to the point where the risk for adverse events is becoming significant. So PCAs, we call them CADs here. We want to do that when we feel like the continuous infusion is the best option. And, that sometimes will happen when we see patients who need frequency of doses or sizes of doses where it just makes sense to spread that out in a continuous way. Ideally, we do this via an implanted port or a midline or a PICC line, but it can be done via peripheral IV. It can be done via subcutaneous port. And so this can be done at home. This can be done obviously in an inpatient setting. And the hospice RNs are going to manage all aspects so that they are, they're going to get the refilled cassettes. They are going to be checking the PCA doses and reaching out to the providers for titration advice. Typically what we're doing there is we're looking at a 24 to 48 hour period and seeing what is what are the actual doses versus the attempted doses. And then what we try to do is figure out is, do we need to go up on the continuous rate to reflect the current demand for extra dosing. Morphine and hydromorphone are the most common drugs delivered this way, and at least in our practice, I can't think of a time that we have done PCA medications that were not these two. So, why is it so important? Well, unresolved pain is going to cause abject misery, and as part of hospice, we're working on mitigating that as part of the human condition as much as we can. But not only that, inadequate pain relief oftentimes accelerates disease progression, and certainly the increased, physiological and psychological stress responses for our patients. Most obviously, pain impairs somebody's quality of life. And again, as we talked about at the top here, one of the primary motivators the primary motivations for good hospice care is promotion of quality of life in the setting of absolutely disastrous disease issues. And so pain management, I think, is pretty obvious to anybody just how important that can be to affecting somebody's quality of life, both what they're physically able to do as well as psychologically how they're feeling day to day. And then thinking very close to the end of life, you get to the point where pain and suffering acts like this anchor. It keeps you stuck here. And we often see in the inpatient arena that patients whose pain is not well treated can't seem to do that inward turn and shut out the rest of the world and start to do the work that's necessary to detach from here and move on through to their deaths. And we will frequently see that when we do a good job at relieving somebody's pain right at end of life, that they do seem to be able to then do that work that they need to do. So let's move on to respiratory symptoms. And again, the terms we're going to use here are dyspnea, which is, sort of just defined as a conscious perception of your work of breathing. And, think about being underwater for a second longer than you really want to, that feeling of panic and that feeling of, I have to breathe, I have to breathe. This can be really frightening and obviously functionally disabling. To some extent, it's near universal at end of life, but it's far more debilitating in the weeks and months leading to somebody's death, in particular with people with chronic congestive heart failure, COPD, sometimes, but to a lesser extent, with space occupying masses. Sometimes people with profound intra-abdominal fluid collections can actually have a physical compression of the diaphragm, and that can cause persistent dyspnea as well. So this is going to look pretty similar to pain, which makes sense, right? Effect on functional status is what you want to start to, drive at. What are they able to complete their ADLs? Do they have declining endurance? How far can they walk before they have to sit down and take a break? Those simple things which really can kind of help you put together a picture of just how impactful that shortness of breath is for them. Just like pain, talking about things that make it better or worse. Almost always exertional efforts are the things that make it worse. But there sometimes can be, you want to look a little bit more granular than that. Is it just, it's the difference between walking 20 feet and 50 feet, or do you get short of breath when you're chewing and trying to swallow? Like, it can be that bad. So really trying to get a sense of what is the exertional level required to stimulate that dyspnea, or do they have it at rest? And remember, respiratory rate and oxygenation do not always correlate with the symptoms of breathlessness. Also, too, sort of on the flip side of that coin is that you'll sometimes see patients who are breathing 25, 30 times a minute and they're blue, and you ask them how their breathing is, they'll say it's fine, that they feel fine, that they can't tell there's any problem, despite objectively, from where you sit, looking like they are practically asphyxiating. And that phenomenon is explained, much like the frog in the boiling water, right? Like you don't really notice that it's getting harder, that it's worse, because they're living with this problem chronically. And there are some adaptive things that they can do, but they just don't feel the way that they look to us. And that can be difficult sometimes when you're doing an assessment to try to rectify the way somebody looks and the way they're telling you that they feel. Some of the non-pharmacological treatments, obviously supplemental oxygen, and this can go a huge way to alleviating somebody's sense of breathlessness, even if it doesn't improve their pulse oximetry numbers. Again, the pulse oximetry numbers I don't find particularly helpful. They are data points, but what the number is and what it isn't particularly predictive, at least in the day-to-day effectiveness or functional status, or rather functional status improvement with management. Some of the classic other interventions, teaching somebody pursed lip breathing, although I have found that most patients naturally develop this habit as their respiratory failure worsens. We talk to people a lot about energy conservation. When you have spent your whole life doing whatever you wanted, whenever you wanted to do it, thinking about task segmentation, thinking about, only spending what energy you have on the few things that you really want to do during the day and letting somebody help you out with those other things can be a really difficult conversation for somebody to have. But helping them recognize that there are ways that they can improve their quality of life by allowing them to do what they want to do if they let somebody else help them out with the things that they have to do. Fans, I've spent time trying to understand what the mechanism for this would be, but particularly people with COPD feel so much better with moving air on their face in particular. It's got to be they seem to be able to have to feel it on their face for it to help. But then, clearly in the summertime, good air conditioning can make a huge difference. High humidity just makes this struggle even worse. And then elevation of the head of the bed, allowing the patient to sit forward when they can't do so on their own, kind of reduces some of that choking sensation, especially if they have a body habitus, which causes some airway obstruction. And also, too, sitting up can allow for some of the expansion of the lungs. So pharmacological treatment, I can't say it enough. Morphine, morphine, morphine. Really the best option. Again, from from a pharmacokinetics standpoint, any of the mu opioid receptors ought to do this as well. But in practice, it really just seems like morphine is the most effective thing. Works to decrease the cardiac demand, increases pulmonary perfusion, and this is a very simplified way to say it, but it basically is telling these feedback centers in the brain that are monitoring all the things that go into making dyspnea sensation that everything is fine, that there's nothing to see here. And so it can really sort of dial back that sensation of breathlessness. We almost always end up using this in conjunction with Ativan. The sensation of dyspnea triggers that fight or flight response, and that fight or flight response and the anxiety of sort of normal day-to-day worry physiologically the same. Your body doesn't know the difference between the two. And so the use of anxiolytic medications to help manage that along with morphine is very common. So much so that I really seldom try, I very often will try to use both of them together right out of the gate if patients will allow us to do so. Much like for pain, these PRN and scheduled doses are similar. Usually for a lot of people, that 5 to 10 milligrams every 4 hours is effective. And if we know that it is a consistent dosing, extended relief morphine is as effective for management of dyspnea, perhaps if not more, in the same way that it can oftentimes be better for pain management. Ativan dosing usually settles out to 1 milligram or 2 every 4 hours. For some people, particularly older individuals, Valium can be a really effective anxiolytic to use as well. And so if you're not getting the effects from the doses of Ativan that you'd hoped, you might think about trying Valium. Clonazepam, when treated, using for treatment for anxiety, it doesn't seem to have any of the effects on dyspnea that you would think, given the kind of medication it is. So usually using that as a quote unquote long-acting anxiolytic for dyspnea is not particularly effective. Cough. All right, so cough is not dyspnea, but it falls into this pulmonary issues, and it can be incredibly frustrating and debilitating. It's not tremendously common that we have like these persistent debilitating coughs, but when it does happen, it's really hard to watch and see. It can cause physical pain and exhaustion from the effort. Obviously, if you can't sleep, that is really, makes your quality of life just miserable. And, people who just have this persistent coughing can actually end up leading to vomiting. Different causes would be, the congestive effects of CHF, irritant from a space-occupying lesion, progression of somebody's COPD. Ongoing cough too is kind of psychologically a reminder of evolving disease process. So managing it not only can help with physically, but also some of the psychological pressures of disease progression. So pharmacology for cough, pretty broad-based, starting with the antitussives. Again, morphine and codeine as antitussives are both fantastic medications. When it's has something to do with clearing airways, obviously expectorants are helpful, and you think about the cough syrups that are the combination and expectorant antitussive medications. Those are definitely things that we use frequently. And we don't see a lot of use of Tessalon pearls, though they are surprisingly effective for nuisance coughs of many causes. And when you are looking for something that just literally sort of anesthetizes that cough reflex, this is a way to go. Obviously, any bronchodilators, if it's airway spasm, wheezing, that is causing this cough, nebulized versions of these medications are ideal. Think about, upping somebody's steroids. Chances are if they're coming to us with chronic respiratory failure of one type or another, they've already been on some steroids. but transitioning to something with a little more potency and using a higher dose of dexamethasone in particular can be a great way to relieve this. And then if cough seems to be part of an overproduction of mucus, either oral or pulmonary, you want to think about the anticholinergics. A word about those, though, is it's a fine line between drying those up and stopping the irritant of cough, and then also making secretions too thick that somebody can't bring them up. And not only from the lungs, but say oral accumulations as well. So we don't use a lot of these, but it's something to think about as a possibility. Um, we don't see a ton of chest PT in hospice patients. However, for help for mobilizing secretions, it's a very good option. Humidified air, typically, cool humidified air will thin out secretions and can kind of break that cough cycle. And then positioning ahead of bed sometimes is effective for managing secretions more efficiently and effectively than any of the other medications that we talked about. And again, if those secretions are part of what's causing a cough, this can be effective as well. Okay, so we're going to move on to anxiety. Um, this is a symptom that seems to be pervasive in day-to-day life for just about all of us, irrespective of whether or not you're dealing with a serious or end-stage disease. And certainly it's easy to imagine that this is a symptom that is tremendously aggravated when you are suffering the physical effects of disease process. So causes of anxiety, symptom-related pain, dyspnea, agitation, and delirium. All of these things trigger that fight or flight response. And it's not something that can be soothed or calmed. You can't talk somebody out of that response to pain or dyspnea. Treating the causes is a really good start. Obviously, treating that pain, treating that agitation, but oftentimes they're not completely correctable, and the use of an anxiolytic medication is indicated either as needed or scheduled. Um, Obviously, there's anxiety that can be caused by medications that patients might be on, stimulants, steroids, thyroid replacements, neuroleptics in particular. I mean, oftentimes those are medications you really do want to continue right through to end of life if at all possible. So, rather than stopping them, you have to think about dealing with the side effects of them. And then obviously people's pre-existing psych history comes into play here. Again, normal is completely normal to be anxious about the process of dying for any number of reasons, both for yourself, concern for families, etc. But if you come to us with an underlying anxiety disorder, it is pretty easy to see how something that was already probably difficult to manage would become even more so in the face of multiple causes of aggravation of this issue. So, it's oftentimes pretty subjective, right? People will tell us they're anxious, and we believe them. Much when they say that they're in pain, we believe them. Certainly in our patients, you can see some of the physical manifestations of this tachycardia, restlessness, agitation, chest pain, hyperventilation. You can observe dyspnea. It's very clear. And when somebody is feeling that anxiety response to it, you can see it on their face and in their body language as clear as the day is long. There are cognitive symptoms, obviously, recurrent, persistent thoughts. I often will, patients who are trying to describe to me what their anxiety is doing to them, especially, we think about like nighttime, not being able to sleep. It's like this spinning, like there's just this spinning, perseverative thinking that's going on in their brains. And it's always, if they could just put the brakes on that for a second, they would be able to focus on anything else, oftentimes getting to sleep. Um, People sometimes think, especially when they haven't had a good conversation about the dying process, or they're really struggling with integrating what's happening to them. They feel like they're going crazy, like, why do I feel so anxious? I'm not an anxious person. And not being able to link the fact that they have physical symptoms or they have medications that have been started that could be driving this anxiety. And, getting them to understand that is the first step to helping them understand why management of it would be effective for them. So treatment, again, this is not psychiatry. We're not doing nuanced management. We are trying to be aware of trauma history. We are definitely thinking about prior treatment interventions, and certainly with hospice patients, we try to continue most oral medications that were effective for people as long as we can, stopping things that were used for management of things like anxiety, depression, that sort of thing is seldom a good idea unless there's a real clear contraindication to doing so. So lorazepam is really easy to use, really well tolerated. Hopefully you see a theme here with these medications. You do want to be a little bit cautious in elderly patients, especially demented patients, as there certainly is an increased rate of paradoxical reaction. I would not, some guidelines say it's absolutely contraindicated in a hospice population. That is not the case. It is definitely worth trying. You will know very quickly if somebody does have that paradoxical reaction. It's not subtle, and so you would know, well, let's get away from that. If that happens, then a good option is to rotate to diazepam or Valium. Again, I can't necessarily explain to you why we see this, but in practice, I've seen that older patients will oftentimes tolerate this drug better than the lorazepam if they do seem to have that sort of reaction. The doses on these are very similar to what we were talking about with, actually they're identical to what we're talking about with dyspnea. And clonazepam is a good long-acting choice. Seldom that we start this de novo in hospice. It's more likely that we would continue this medication that somebody was already on. And so, what we see in hospice patients is often like this, the 0.5 to 2 milligrams twice or 3 times a day. Certainly, there is room for increased dosing with that if necessary. But again, this is something people usually have come to us on, and if they need to have further anxiolytics medications brought on board, then we would think about leaning on larger doses of Ativan or Valium as we're sort of titrating to a point that somebody's more comfortable. Other ways to help somebody manage their anxiety, really, you got to talk about it. The anxiety surrounding impending death, it can't be ignored. Patients may choose to ignore it, and you can't make them address it, but really bringing to bear the sort of full resources of hospice, both of spiritual care and social work, but not just those two disciplines, but anybody who touches, the patient's care through the day, the nurses, the NPs, the docs, the CNAs, anybody can make that connection with somebody and allow them to sort of talk and give voice to their fears and their worries. And it may be sometimes that there are things like, there's a estranged family and they've been afraid to ask other family members to reach out. Things like that, aren't going to fix the fact that they're dying, but maybe can assuage their worries about that one particular thing. And that might be the thing that's really driving some of their non-physiological related anxiety. And it's something that hopefully hospice could help with. All right, so we'll move on to delirium and agitation. So this is a little bit more difficult to describe completely. It's sort of like, is one of those things, it when you see it. And so delirium is defined as acute change in cognition or awareness. And delirium of one sort or another, we usually refer to as terminal delirium, is almost universal as people approach life. With all of these symptoms, they are almost all universal. It's going to be a difference in just their severity for each patient. For some people, it's minimal. For other people, it's obviously profound. But it's very seldom I have seen somebody dying who was still alert enough to communicate in any fashion that didn't demonstrate some signs of delirium as they approached end of life. Agitation is, the physical manifestation of their delirium. And the confusion, is that disorientation, difficulty with communication, hallucinations, either auditory, visual, or otherwise. And these things are oftentimes all occurring concomitantly. And we usually will kind of use the generic term of agitation to describe them all. Like I said, delirium is nearly universal at end of life. It can certainly be worsened by underlying dementia or psychological issues. Certainly, if some of those psych issues are no longer able to be treated with medications because the patient cannot tolerate their chronic oral medications. Can be due to encephalopathy, which is almost always multifocal for our folks. Infections, toxic metabolic. And then there's definitely this phenomenon of just terminal agitation that doesn't have an easily definable cause, though if we were able to do extensive lab work on these patients, I suspect we would find some common pathways. Truth be told, at the end of life, it's hard to know what the exact cause is, but honestly, the cause isn't tremendously important because we're going to treat them all the same way when we're talking about people who are very close to end of life. This is a little bit different when we are talking about patients who are further upstream, who are experiencing agitated delirium related to something like, dementia, Parkinson's disease, that sort of thing. But relief of suffering due to delirium and agitation is just as important as the relief of pain. And I think sometimes this goes by the wayside, but you've got to try to put yourself in the shoes of a patient who is looking out through a pair of eyes and seeing God only knows what, hearing God only knows what, and trying to exist in a world where either things are terrifying or they just can't understand them, and really think about how severely impactful something like that would be. And we can't stratify it in a way that, gives it any, less importance than something like pain. So the H word, Haldol, really is the best thing going for our patients. It has a really significant negative history, and a lot of providers have really negative or have negative connotations associated with using this, largely due to issues with skilled nursing facilities using it in the past, being seen as, quote unquote, chemical restraints. A word about Haldol I would share with you is that it is not in and of itself a sedating medication. And if someone seems like they've been sedated after receiving Haldol, it's almost certainly because the patient was exhausted from their disease process, from being stimulated, from being constantly brought back to awareness by their pain or their dyspnea or their nausea. And they're trying to do this work of withdrawal, or they're trying just to sleep because they're exhausted. And when you quiet that kernel of agita, then they're able to do so. So if somebody seems like they were just knocked out by getting Haldol, it's probably because either they've been trying to actively die for a while, or they're exhausted and they need to go to sleep. The doses that we use in Haldol, rather in hospice, are quite low as compared to acute interventions that you would see, say, in an emergency room. But they can be incredibly effective. Thinking too about another population where Haldol is often seen as completely verboten would be those patients with Parkinson's disease. And rightly so, patients and families have been told by their neurologists that they should, under no circumstances, ever utilize Haldol, as it works by decreasing the effects of dopamine, which obviously is, a big part of management for Parkinson's. At the end of life, though, this would not be contraindicated because we are almost always dealing with severe agitated delirium in a patient who functionally is bedbound and incapable of movement in any case. And, even what processes they still can control, if it's swallowing, handling their own secretions. If for some reason that would be negatively affected by decreasing the availability of dopamine, it's in the context of somebody who is going to be dying soon, no matter what happens. So that can be a really difficult conversation to have with patients and their families who have been on dopamine replacements or treatment for their Parkinson's disease for a long time. It's really been, told to them for years not to do that. So it requires a lot of education in that case. So treatment for delirium, if you can, again, we talked about earlier, there can be like dementia patients in particular who come or develop significant agitation and delirium, and management of their pain really rolls it right back. And there could be inciting medications. And the other one really common is infection. Think about UTIs or pneumonia in particular. To wit, another common thing that we will see is patients who come on to hospice services, perhaps from the hospital, who had pneumonia or a disseminated infection from something like a urinary tract infection, and the family, elected, because of the patient's quality of life beforehand, to pursue comfort-focused care. We'll sometimes see, if that patient is able to fight off that infection on their own, that they will return back to baseline cognitively, or close to baseline cognitively, which really sort of underscores that these other issues can exacerbate delirium or agitation, and absent those, the patient would be back at their, getting quote unquote normal. So other pharmacological treatments, quetiapine, Seroquel, which is Seroquel, olanzapine, the Zyprexa, risperidone. These are other good options. Sort of the irony about people who want to avoid Haldol because they feel it's sedating, they'll actually turn to Seroquel and Zyprexa, which is fine because they're very good at treating delirium, but they're also quite sedating when given at effective doses. So much to the point that sometimes, Haldol might be effective for managing somebody's delirium, but they still remain quite agitated, and we would then transition to something like Seroquel in particular, so that we can actually get that sedating effect when we're trying to help somebody, particularly like sleep at night. We would like to have that effect. Risperidone is not approved by the FDA for treatment of behavior problems in older adults with dementia, but it remains oftentimes the first line for ALF or skilled nursing facility patients. So we will see a lot of patients come to us with that, even though it's not necessarily the most effective option. Benzodiazepines are not a good first-line treatment for delirium. Adjunctively, when we're managing, either physiological or underlying anxiety issues, they can be helpful, but oftentimes not a good first choice, not particularly effective. And these are the patients that oftentimes, if there was going to be a paradoxical response, I've seen more often than I have in other patients. There are lots of good research and work on non-pharmacological treatments, relaxation, distraction therapies, presence of family and staff. These are all effective earlier up the line, and can, provide some relief. The patients that I'm talking about today are those folks who have really progressed beyond the point where they have the awareness or the executive function to even be aware of the soothing effects of those other interventions. And so then we're really looking towards medications to help us bring some peace and quiet for that patient. All right, nausea and vomiting. This is something that, again, is pretty common across the board with hospice patients. Fortunately, it's not severe and persistent for most of our patients, but for those that it is absolutely miserable. It really can be really severe and debilitating, and by virtue of that, cause significant decrease in quality of life. There are many potential causes, with medications being primary. Any process that affects gastric emptying or causes constipation or paresis. The processes like, liver and renal failure, where you can see urea excretion or bile excretion into the gut, inability to conjugate, ammonia, and then, physically, or rather increased physical pressure intracranially, either related to, space occupying mass or edema from a large stroke. Irrespective of the cause, the result is this indirect stimulation of the emetic pathway in your brainstem. And that stimulation can come from many different points, but it all ends up sort of funneling down to the same spot. The points of intervention in this pathway, these are not all of them, but these are the three that we most likely would deal with, is the dopamine related part of it, histamines, and then the serotonin receptors. We have a pretty compact toolbox of antiemetic medications that we use based on sort of accepting that these are the three most common ways that we could intervene. Sorry about that. All right, so the treatment for nausea and vomiting, medications that prevent nausea. These are the histamine and the serotonin active drugs. They are better at preventing nausea than they are at managing it when it's already occurring. Think, like preoperative medications for motion sickness, that you would use prior to going out on the sea. That would include your ondansetron, promethazine, metoclopramide, scopolamines, meclizine. In hospice, we don't use a lot of these. The most common ones would, of course, be the ondansetron and the promethazine. Medications that actually treat nausea, and these are the dopamine-focused medications. We use these preferentially, again, due to the lack of sedation side effect. They're really rapid onset, and the effectiveness is pretty is close to universal. The dopamine is a really important neurotransmitter in the vomiting center of the brain, and Haldol, it acts as an antagonist. So it really ends up being a very powerful antiemetic, and it's been in use, I think since the 50s for this purposes. The prochlorperazine and the chlorpromazine, also effective. We don't use a lot of the thorazine. The compazine, though, is something you've probably seen more often. But again, for our patients, the Haldol really does seem to be the way to go. The dosing is the same, whether it's oral, IV, rectal, subcutaneous, it's all the same. So it makes a very simple intervention. Steroids can be effective, especially if the patient's nausea is being caused, again, by space-occupying cranial masses, if they've had recent chemotherapy. And these drugs, they inhibit the serotonin pathway. Irrespective of what you're doing or what's going on, if there isn't a contraindication to use steroids in a hospice patient, there's very few times when a little bit of boost from Decadron doesn't go a long way. And certainly I use it almost all the time adjunctively if I have somebody who has chronic persistent nausea. One of the other, this is a little bit, this is pretty narrow sort of intervention, but bisphosphonates and IV fluids can be really effective when you have severe electrolyte imbalances of calcium and phosphorus that you see with lytic bone lesions. The few times that I've done this in my practice, it was almost like a light switch. Somebody just shut off this person's nausea when we sort of washed out those electrolytes and tried to promote a little bit of stabilization of the bone. So that is something that is not common, but certainly should be considered. So talked a little bit about this already, but I think it bears repeating. Haldol really is the preferential choice here. Again, it's in and of itself not sedating, because it really is working kind of at the base of the tree, if you will, for all the pathways that lead towards stimulation of the emetic center. It is really very much cause agnostic. Dosing is very simple. You'll see that it looks exactly like the recommended dosing for lorazepam. And again, at these doses, these are very low doses when compared to how it is used in most other settings. Again, like I've said, amounts and frequencies aren't important, but when you are talking with families or talking with providers who may have some hesitation at using this, kind of helping them understand how it works and that what we do when seen in the light of other practices is really, minimal. Sometimes that can be helpful in promoting acceptance of use of this medication for treatment for somebody's nausea. All right, so just to summarize real quickly, pain impacts functional status and overall sense of well-being. Again, this is not news to anybody, as we've all experienced this. The causes are oftentimes multifactorial, and for patients with severe symptoms, moderate symptoms, even minor symptoms, when you're talking about a terminal disease, it can be significantly life-improving if those are managed well. Dyspnea, same, functionally limiting, promotes a lot of anxiety and fear, and requires a multimodal approach. You want to think about narcotics, anxiolytics, and non-pharmacological and non-medication interventions. And oftentimes it takes an amalgam of all of those in order to effectively bring any relief from this. Anxiety is a source of and caused by symptoms at end of life. It's a complex interaction, and relief for the driving symptoms and adequate medication management is essential to promote quality of life. Delirium, very disturbing symptoms for both patients and caregivers. Let's spare a thought for the caregivers as we're thinking about all of these. But in particular, the behavioral aberrations that you see with delirium can be particularly impactful for caregivers, as they sometimes can involve, saying things and doing things that are so out of character for the patient that it really does become traumatic for the caregivers. Medication management is key, with attempts to mitigate possible causes also indicated. And last but not least, nausea is oftentimes overlooked but incredibly disabling symptom of advanced and end-stage disease. It's caused by a complex melange of effects of these end-stage diseases and does require aggressive management. I hope that this discussion has been helpful for you. Again, it is not necessarily an all-encompassing treatise on how people end up with these symptoms, nor how they can be managed. But I hope that this is helpful in helping you understand the common causes and common interventions of symptoms that you are most likely to see with your hospice patients. I want to thank you very much for taking the time to listen to this today. And if you have questions, feel free to contact me at any time.